Hi, you are in the ladies' room with Dr. Donica, the only public ladies' room you can enter anytime without ever waiting online. I'm your host, Dr. Donica Moore. We'll be having real conversations with real women about really intimate issues. They may be embarrassing, sad, or funny, but they will always be interesting and informative. You know, like the best conversations you've had in ladies' rooms with your best friends, or total strangers and a physician. Please join us.
Hello, and welcome to another exciting episode of In the Ladies' Room with Dr. Donica. Now, in 1989, I wrote an article published in the Journal of the American Medical Women's Association called The Other Side of the Bedpan. And in this article, I talked about my experiences as a physician having to adjust to the new role of being a patient while I underwent major spinal reconstruction surgery. Today, I'm talking with another woman physician who had to adjust to being on the other side of her bedpan. She wrote an article, an op-ed in the Chicago Tribune in 2017 about healthcare based on her personal experiences as a patient. Now, before we hear her very compelling story, let me tell you a little bit about the backstory for our guest, Dr. Sarah Nadeem. She's an assistant professor of endocrinology and medicine at the Aga Khan University Hospital in Karachi, Pakistan. She was inducted as a fellow of the American College of Endocrinology in 2015. She completed her medical school training at the Aga Khan University, followed by internal medicine residency at William Beaumont Hospital in Michigan, and an endocrinology fellowship at the Mayo Clinic in Rochester, Minnesota. She was on the faculty at the Loyola University Hospital in Chicago, where she had a busy clinical practice, was an active member of the Stritch School of Medicine Curriculum Review Committee, and established the Women in Medicine Group. She is an active member of Women in Endocrinology Committee of the Endocrine Society, a member of the AACE, the Endocrine Society, the Pakistan Endocrine Society, and an ambassador for the National Osteoporosis Society. Currently at the Aga Khan University, she established the Women in Medicine Committee, mentors medical students, residents, and is in charge of the endocrinology rotation for medical students. Her research interests include diabetes, technology, and bone health in cancer patients, with many publications. Dr. Nadeem frequently presents nationally and internationally about these topics at medical conferences, and now we're going to hear about her experiences on the other side of the bedpan, which included being diagnosed with breast cancer while pregnant at age 35, and that was with her third child, I might add, followed by chemotherapy, surgery, Crohn's disease, and cardiomyopathy. And somehow she manages to keep her great sense of humor, a great smile, and her passion for helping others. Dr. Nadeem, welcome to the ladies' room.
Thank you. Great to be here. Thank you for inviting me.
Well, you know,
thank you for the kind introduction.
Oh, it is my pleasure. And, you know, we connected on Twitter, which I think is the great connector of the universe now. I think it's pretty incredible that two physicians who've taken an interest in the same topic can connect, and one is in Pakistan and the other one is in New Jersey. And we have all of these things in common, including technological glitches that we're going to run with today, kids' demands, and professional demands. So let's start somewhere. Tell us where the story begins with you becoming a patient and entering this healthcare sort of maze/nightmare with your diagnosis of breast cancer while you were pregnant.
Right. I mean, it was just something totally unexpected. I don't have any family history of breast cancer, and I was 35, pregnant with my third child. And I had come home after a late evening busy clinic, which ended at 7 p.m. So I'm home, I'm just changing into my pajamas, and I do a breast exam. I used to do a regular breast exam, and I felt something in my right breast. And I was like, well, this can't be happening because, you know, I'm too young. It doesn't happen, you know, I don't have a family history. And I'm totally healthy. I had no medical problems up until that point. But, you know, I had a bad feeling, and I kind of kept persisting with my gynecologist, who initially dismissed it as, you know, that's just because I was pregnant.
How far along were you in the pregnancy?
I was about 20 weeks, 21 weeks.
Oops, I just dropped the phone.
Yeah. So then what happened was that I was just like, whatever it is, even if it is some myth, that's it. The first day I was really really nervous, and then she reassured me that it's probably nothing, but have it drained. I said, okay. So I went, and the radiologist technician's face kind of just dropped as soon as she put the plug on. And I was like, you can't see it. And she was like, no, I can't tell you what it is. The radiologist will speak to you.
So she did an ultrasound first then.
Mm-hmm, mm-hmm.
So, and just so that, and just to let everybody know who's listening, since you were 20 weeks, you were about exactly halfway through your pregnancy.
Exactly. Just halfway. And then the radiologist came in and she was like, well, who told you this is a cyst? Because just look at it. And she just flipped the image for me to look at it. And I'm an endocrinologist. I don't do breast cancer, ultrasounds, anything. But I do thyroid ultrasounds. And from my medical school days, it just looked like a nasty, like it looked like cancer. Mm-hmm. And so that's where it all started. She said, we need to do a biopsy. The biopsy results came back the next day. She called me and gave me the diagnosis because I'd insisted I can't wait over the weekend. You have to tell me.
Right.
So she said over the phone. I said, yes, I need to know over the phone.
So right off the bat, there's a couple of differences that already happened because you were a physician versus a non-physician patient. So the first thing is that you were able, the radiologist came right in herself and was able to flip the image, and you were able to look at the image and understand what you were looking at. They probably wouldn't have really done that with a patient who wasn't a physician. The next thing was that you were able to advocate for yourself and get the radiologist on the phone and say, no, I need to know right away, and I can't wait. And that's...
And she was very helpful, but the whole connection of being a physician. So she said, usually pathologists don't come in on Saturday, but I'll speak to my friend who can maybe just do a quick review. So yes, that's something that was different for me because I was in healthcare, a colleague. Mm-hmm.
Yeah, and ironically, not everything is better when you're a doctor. There are a lot of downsides that we'll talk about also, because some things tend to get dropped through the cracks when we go around and we don't do the normal procedures. So anyway, the pathologist looked at it and said...
So the pathologist looked at it, and so the call at from radiology, she said, it's what I was dreading, it was. And I was like, okay, what? She said, it's, invasive ductal carcinoma, high grade. And I don't really remember much after that because, once you hear those words, cancer. And although I'm a doctor, but she was telling me all of this technical stuff, and I would just said, so it's cancer, because I couldn't comprehend at that time, the whole stage or whatever. So I said, what do I do now? So she said, schedule an appointment with a surgeon. I said, not a cancer doctor? She said, no, just see the surgeon first. I said, okay, thank you. And that was it. And then my husband and I kind of scrambled to understand. It was a Saturday. You couldn't call anybody to schedule anything. What are the next steps? And I ended up actually calling my friend who's an oncologist in Oklahoma, asking her, what are the next steps? What am I supposed to do now? Where do I go? Do I go to the ER? Do I go to surgery on Monday? What happened?
So this is the other problem about how disjointed our medical care is. I just recently had this experience with one of my children who was seen in an ER, and they follow up with, whatever specialist, but they don't tell you a recommendation of who to follow up with. They expect that you're just going to look up in your, Rolodex or your yellow pages and find a breast surgeon. So is your husband a physician as well?
He is. He's a nephrologist.
Okay.
So again, he has nothing, so a kidney doctor, right? So nothing to do with oncology or breast. And then so we were scrambling, okay, because I'm pregnant, and I'm like, what does this mean for my pregnancy?
Well, and you were also at a very critical point in your pregnancy, where time was of the essence if if you had to make some decisions. So
that was my fear. Mm-hmm. What happens to my pregnancy? What happens to my baby? Mm-hmm. Because, in all of this so far, the radiologist is usually not the one who gives news about cancer diagnosis, but that's just how it happens.
Right. And usually the radiologist would have talked to your gynecologist, and then you would have had to make an appointment to see your gynecologist, and more time would have passed. So you would have missed some critical deadlines. So how did you finally find a breast surgeon that you went to?
So I just, I called my oncology friend in Oklahoma. She then connected me with a surgeon. Actually, one of my husband's friends connected us to a breast surgeon in Chicago, because that's where we were.
Mm-hmm.
And but he said, I'll have to talk to her on Monday. There was a woman surgeon, because I don't know if there's time, like when the appointment is. So Monday, when my husband calls everywhere, because we've got these really excellent medical centers, and most of my care was at Northwestern ultimately. But we called everywhere, and most of the good breast surgeons, and I was just Googling like best breast surgeon, Chicago. They were booked out for a few weeks, and Ali said, but then she's just diagnosed with cancer, she's pregnant. So they said, but do you have a pathology report? And we said, no, we just have a verbal report. They said, you can't schedule an appointment with a surgeon unless you have a pathology report. And I was like, well, I don't know when I'll come. So it was, this whole thing, like I thought, there's so much time being wasted, but I don't have the answers. And I could understand where they were coming from, because I understand I wouldn't treat somebody for a thyroid disease unless I had a report, right? Not
right.
verbal.
Right. It's very different when you're the patient.
Right. So I got what they were saying, but inside I was just like, that doesn't make any sense, So ultimately we went to see a surgeon, I think after 2 days, who was able to fit us in because of her friend's friend. And she was very nice. She kind of walked me through the whole diagnosis and said, it's very rare, but it does happen. But I don't have a lot of experience in pregnant patients. I'm going to refer you to Northwestern or University of Chicago, where I'd managed to get an appointment 3 weeks later, right?
And let me also add that very few breast surgeons have extensive experience with breast cancer and pregnancy, because the good news is it's very rare. The bad news is when it happens, time is of the essence. And you just said you got an appointment for 3 weeks later. So just to connect the dots for everybody who's listening, that means it really was no longer an option for you to wait to hear what the diagnosis was or the staging of your cancer before you made a decision about whether or not you were going to terminate the pregnancy. And I don't know what your views on that were, or if you were thinking about that. But that's a real issue with women who develop breast cancer in pregnancy. I myself had a situation where I was 34 and a half, and I was pregnant, and I was at a medical conference. It was the National Congress on Women's Health. And one of the physicians who was one of the original women cardiologists, who was a chairman of an academic department, showed up, and she looked terrible for her presentation. And I said, what's wrong? And she told me her 35-year-old daughter, who was a physician, was pregnant with her second child, and she had just been diagnosed with breast cancer. And she was a mess. And I went up to my hotel room and did a breast exam on myself and found a lump. And within 24 hours, I was in surgery. I didn't even bother having a mammogram or an ultrasound. I found a breast surgeon and just went straight to surgery and had it removed. I was 16 weeks pregnant at the time. And I literally set the timer for 10 minutes. And I allowed myself to obsess for 10 minutes what I was going to do. And of course, the punchline is you wait for the biopsy. And in my case, it was not malignant. So we were lucky. But I think that highlights a really important point, is that most women, including physicians, don't do regular breast exams during pregnancy. And we don't recommend them. And when you're 34, 35 or older, and it's yours, in my case, it was my second pregnancy in 16 months. Actually, my kids are 16 months apart. So it was my second pregnancy I had only had 6 months between my pregnancies. That, of course, increases your risk for breast cancer.
Right.
And how far apart were your 3 children?
So my youngest was 5 years younger than I have 3 daughters. So my youngest baby is healthy, but she's 5 years younger than my middle child.
Got it.
So it was spaced out apart, but you're right. I was not examining my breast as regularly because, it's hard, and they say, you can't rely on the findings because the breast becomes bigger, the tissue changes, and so forth. But this was a definite lump. And I remember asking that surgeon that I could get in to see, was like, what happens to the pregnancy? And she just, I mean, I think it was a difficult situation for everybody also when they find out, oh, she's pregnant, she has breast cancer. But so she just said, you know yourself as a doctor that mom comes before baby.
Mm-hmm.
And I think she said it in the right intent, but I was just so mad.
Yeah.
Because I was like, we're just talking about, she didn't even say baby, she said fetus, right?
Mm-hmm.
So the mom comes before fetus. And I get it totally. And I totally understand, like, if it was my life or death situation and somebody recommended, it's a very hard decision, but I would have considered it, right? It was just like, I felt like nobody was listening to me,
Mm-hmm.
and nobody really cared about the pregnancy. They cared about me, but they didn't care about the pregnancy. And I wanted answers like, what's the best thing if we can make both of these things go together? And that person didn't have an answer. And her answer was very clear-cut and, I don't know, just very non-emotional, whereas it was such an emotional time for me. And I don't know, that sentence just has stuck with me since now. And I always feel like anytime I'm going to advise a pregnant woman about anything like thyroid disease is what I do, I'm not going to talk about the fetus as if, I don't know, as if that thing doesn't matter because as a mom, you care about your own health and the baby, but you also care about, your older children. So I knew all of that I have to be around my older children, and this one isn't born yet, so I have to be alive for me to take care of them. But it's so nuanced, and I didn't know whether there is a better way to say it, but it just stuck with me. And I just felt like, and I came home and I screamed, and I was talking to my husband saying, nobody else cares. They're just treating me like any other woman with breast cancer, but I'm pregnant, so it must be different. Right? But they don't have the answers. And where do I go? So I go online again. Mm-hmm. And there is this wonderful group called Pregnant with Hope or Hope for Two.
What is it? Say Pregnant with Hope for Two?
No, it's a Hope for Two.
Hope for Two.
Hope for Two. And it's for women who are pregnant and who are diagnosed during pregnancy, any stage of pregnancy, for any cancer. Mm-hmm. And so that actually surprisingly was the only resource which gave me a lot of information and reassurance about, being in the second trimester. Like usually if you are in the first trimester or so, the pregnancy is aborted to ensure that, because the chemotherapy and everything that you get is quite harmful to the developing fetus. So that makes sense. But after the second trimester, there's no clear-cut guideline. So, long story short, eventually I went to meet with the oncologist in a week, and then a cousin of mine, actually, who lived in Switzerland, she had some connections. She pulled some strings, got me the email for the breast surgeon I wanted to go to. I had an appointment in 3 weeks, and I emailed him, and he replied in an hour.
That's awesome. That's awesome.
Yeah, so that's when I finally thought, okay, I'm in the right place now. Things are happening, because I couldn't wait 3 weeks. I couldn't imagine waiting 3 weeks, because on the phone, the genetic answer was, it's not an emergency. With breast cancer, it doesn't matter. It won't change your treatment, even if it's 3 weeks later that you see the.
Well, see, that's a fallacy about pregnancy, because of course pregnancy is an estrogen factory. And, having an estrogen, any estrogen sensitive cancer, but if it's an estrogen sensitive breast cancer, you are exposing that cancer to very unusually high levels of estrogen, which is basically like pouring gasoline on a fire.
And it will grow really quickly, yes.
But of course, as physicians, one of the things that's very frustrating to us is when we don't have the answers based on double-blind, placebo-controlled clinical trials. Right. And I don't know of any clinical trials that were done with breast cancer in women who are pregnant, because of course we don't like to do clinical trials in pregnancy, period, let alone, with women with breast cancer. So I think getting back to this question that you raised, which is really important, which is about the sensitivity of the pregnancy. I think the only way to deal with that is to say very directly, I know that your baby is very important to you, and I am sorry, but we don't have answers, hardcore answers about the effect of this cancer on your pregnancy. But I think that this is something that as a medical community, we should probably fast track patients who are currently pregnant. And they are exposed to different risks. You know, first of all, if you have to have any surgery on your breast when you're pregnant, even a biopsy, which I did, what's the first thing that 100% of pregnant women experience when they're pregnant? Is breast engorgement and sensitivity.
Right. And blood supply is being diverted to the breast so much, and there's a higher risk of hemorrhaging there.
Did you have any complications of your surgery?
They didn't do it in pregnancy.
So you waited.
So I met the surgeon, and the surgeon and the oncologist both said, you will start chemo first, because chemo saves lives. Surgery doesn't really have mortality benefit for you. And but it was just shocking being a physician. You know, you think you have cancer, you get it out first, and then you do the chemo. But and then the surgeon was like, the risks are too high because of engorgement, because of the increased blood supply, and because it's so big. It was a 4-centimeter mass.
Okay.
Is that there's a very high likelihood of complications, and they were very helpful and walked me through the whole pregnancy aspect of it, like what are the complications, potential, what they do know. Actually, the oncologist printed out a paper, which was like a retrospective or like you said, there's no clinical trials, but whatever data there is about women who had chemotherapy during pregnancy and the long-term outcomes on the baby. So that was really reassuring. And he was like, we can start chemo this week. And that's what he suggested, because he was like you said, it's a high estrogen state and it's going to just keep growing. We need to do chemo first, shrink it, take this pregnancy to term, deliver the baby, complete chemo, and then you go in for surgery. So I was just like, I came home, I couldn't understand. I read a lot, I read this article. So I was like, well, the tumor's still there, the cancer's still there, but that was the right, whatever information there is, the little information, chemo does show, neoadjuvant chemo in a younger patient does show mortality benefit versus getting surgery.
Well, in many cancers, in women who are pregnant or not pregnant, doctors like to give chemo first because, especially in an aggressive tumor or a larger tumor, it can actually decrease the blood supply to the tumor and shrink the tumor first, and then the surgical outcome could be potentially a little bit better.
That's correct.
Or a lot better.
Yeah. So that's what they said. And I was supposed to get like a triple chemo, but the third one could not be given in pregnancy because it passes through the placenta. So I was given adriamycin and cyclophosphamide, which are 2. So it's an ACT was my regimen, but the T cannot be given in pregnancy. So I started AC, and I was just like, it was just unbelievable. I wrote a lot. There's this like Caring Bridge website to update people about people if you're in the hospital or sick. And so for me, it's cathartic to write. And so I wrote about, like, I felt for real that, here I am, a baby, a life is growing inside of me. And yet at the same time, there's something in there which is trying to kill me. Now I'm going to put poison in my veins.
To kill it.
How do you get it up your head around all of this? But I was a good patient. I know a lot of doctors sometimes aren't good patients. But I was like, I'm going to totally trust you. And I told my oncologist and my surgeon that, don't treat me like a doctor. Don't assume I know, because I don't know anything about this. And right now I think my brain, is emotionally so upset that I can't I can't recall what I may have read in medical school. So just walk me through everything. And they were wonderful.
Yeah, I think many times when physicians treat other physicians, we assume that you have a lot more knowledge about this particular condition or your own particular condition than they've told you or explained to you, which is pretty ironic when you're in a situation where they're not even sure of the information. So for starters, one of the other questions about time being of essence in pregnancy is, did your OB, well, first of all, did you switch to a high-risk OB, or did you stay with your current OB?
Yeah, so they said they would want me to switch to a high-risk OB, but I was, because they said it's not because of, not because of your age or anything like that, but because they wanted to, because my initial OB, I've had 2 healthy pregnancies, no medical problems. I'd chosen, just a regular OB outside of the university system. And so they wanted one so that they could coordinate the chemo cycles and plan it so that if I was in between chemo cycles and not at my nadir, then they would induce me.
Okay, so that was my next question, is whether you were going to be induced early or whether you continued the pregnancy. So at what point did they induce the pregnancy?
At 36 weeks and a couple of days, so, just close to 12.
Okay, so let's explain this to everybody. A full-term pregnancy, we usually say it's 9 months, but in medical speak, it's 40 weeks. And it's not really exactly 40 weeks. It's actually 38 to 42 weeks, or 41 and 6 days. So the full term is any time between 38 and 42. However, we know that once a baby gets to 36 weeks, it's pretty fully developed. Ideally, we want the baby to stay in the mother's uterus for as long as it needs to. But in cases like this, your doctor could induce labor, which means, to bring on labor earlier to get the baby out of you sooner so that you could get the other chemotherapy that you needed sooner.
That's correct, yeah.
So you went in at 36 and a half weeks.
Almost 37, almost 37. So they induced me, the induction went fine. I was totally bald, so I lost all my hair after the first chemo cycle, and that was every 3 weeks. So my hair started falling out in clumps, then I had shaved, and I was, I pushed, and this was an easy birth actually. Even with induction, I'd heard that it hurts more, but it didn't. Barely half a push and she was out. And she had this thick head of hair. At that time, I was just satisfied because I was like, I'm bald. And, I read everything, and they told me again and again that it won't cross the placenta, the chemo.
And so as soon as you saw the hair.
I was like, it didn't cross. She's fine,
So just so everybody who's listening gets that nuance, one of the complications of chemotherapy is it causes you to lose your hair. And you were worried that it would cross the placenta and affect the baby, but the baby was clearly born with a full head of hair, meaning it didn't affect her in that way. And how much did she weigh?
So she was 7 pounds, so a healthy weight. Totally fine. They checked her out, everything, because I still had that nagging speed.
Of course, every mother does with every baby.
Right. So, but thankfully, she's totally healthy. This year is 5 years since I was diagnosed. So she just turned 5 last week, and she's healthy. Developmentally, physically, things are good. Then after her, the plan was, I had 1 more cycle of chemo left. That was finished, and then my oncologist changed his mind and said, they were monitoring the. Then I had my first mammogram and ultrasound, and because I couldn't, they tried to do the mammogram with a shield around my belly when I was pregnant, but it wasn't that great. So then they did an extensive one, and they said because the tumor was not shrinking as fast as they thought it would, that they would go in and do the surgery and then continue chemo.
So how far postpartum were you when you had the mastectomy?
6 weeks.
Okay. So, and just to let everybody know, so when you were 6 weeks after giving birth, you then had a double mastectomy. And did you have your ovaries removed at the same time?
No, so that's, I had requested because after my baby was born, between the diagnosis and the baby, they had checked, all women under age 40, if they're diagnosed with cancer, they recommend genetic counseling.
Right.
So my genetic counselor said there isn't any history, so, I'll just email you the results, but, I'm going to send it, but I don't think you're going to be positive. It came back positive. I am a BRCA2 carrier. So that changed everything, which basically means if you have BRCA2, you have a higher risk of ovarian and bilateral breast cancers and colon cancer and pancreatic cancer.
So let's just explain to people what BRCA is. We've talked about that on previous episodes of this podcast. In fact, we talked to a young woman who was BRCA 1 and 2 positive, who decided to have a prophylactic double mastectomy and oophorectomy, even though she did not have any breast cancer. But BRCA 1 and 2 are different genetic markers for an increased risk of breast cancer. So BRCA is BRCA, breast cancer. So you had BRCA 2. This is a hereditary genetic marker. I don't remember what percentage of women are BRCA 1 and 2 positive.
Off the top of my head, I don't know. And the other thing is, because I'm from Pakistani heritage, we don't really have numbers about, or we didn't have them yet. There have been a couple of papers since then. But BRCA 2 is actually seen more in certain populations. The Ashkenazi Jewish population is of much higher prevalence. Mediterranean people, but I'm neither, right? We're Pakistani, which would be some Arab Indian heritage. And there just isn't, I think, enough studies to know for sure. So I was just shocked. But the risk of developing breast cancer is about 70 to 80%, and ovarian cancer is over 40 to 60%. So I asked my, the breast surgeon that that I met with a gynecologist oncologist and said, can you do the ovaries out at the same time? And she was like, that's going to be too much for you. And she was very considerate. My age, and she was actually also pregnant at the time when I saw her. So it's so ironic. But she was like, Sarah, you can't deal with, just going into directly, pregnant baby and then straight into menopause within 6 weeks.
Yeah.
So it's okay. We'll do the ovarian cancer, or taking out the ovaries prophylactically in 6 months. So at least get through it one at a time. And I was like, okay. But I think she gave me the right suggestion. And so I had a double mastectomy. And the thing was, I said, can we delay it to 6 weeks, 7 weeks? Because initially they wanted to wait at 4 weeks. But I was like, I was restricted. I couldn't lift anything more than 5 pounds. And my baby had been born at 7 pounds. So I couldn't breastfeed her. And then I was like, I won't even be able to hold her for, another 6 to 8 weeks. And how will I ever bond with her? How will she ever know that I'm her mom? What if I die? And then she won't even have that memory, right? But so at 6 weeks, and my mom stayed with us throughout. Without her, we wouldn't have been able to do much because, my husband was making sure the older two were, as normal as we could continue their, regular routines. And my mom took care of the baby when I couldn't hold her after the surgery.
Yeah, that must have been very, very stressful. Did you develop any kind of postpartum depression after that pregnancy?
So it's hard to say. I started seeing a therapist in between, I think a month after diagnosis. Once I got the surgeon, the oncologist, everything, there's a nurse navigator that breast cancer patients, most centers have. And she was a social worker, and she was a great resource to talk to just on the phone. Sometimes she would say, how do you break the news to my kids? And she really helped me. And I started going to a place called the Wellness House, which is in a suburb of Chicago, where it's for anybody touched with cancer and their families. And they had a good child psychologist there as well. So my kids started going there, and then I started going, and I continued going, for a year or 2 years after the diagnosis. So I don't know if I had an element of postpartum depression there. I was never diagnosed with or given antidepressants, but I was definitely told that, I was struggling with the diagnosis, with everything.
Right. You had about 16 reasons to be struggling.
Yeah. So I later after my surgery, then I had weekly chemo. So weekly, after chemo, I used to see, before chemo, I used to see my psychiatrist and then go for chemo.
So what do you think? What do you think the lessons were that you learned about navigating the healthcare delivery system that you didn't really realize as a doctor, but that you then learned the hard way as a patient?
So the first and foremost was the disjointed system. And that's like in the United States healthcare, that kind of really, being a doctor, I made sure I actually printed out my entire history in bullet points. And I kept adding to it, and I had my medication list and everything, because every time I would go to, like, say, the oncologist's office, and there was a resident or a medical student there, and I would start with my history, I could see their eyes kind of gaze up. Oh my gosh, this is the most, complicated patient. And I had been there. I had been one of those residents where, you would be like, oh gosh, why am I stuck with this, patient? Not that you don't like the patient, it's just that it's going to be a very difficult history to present, right? So then I would always hand them the paper, and then they would be like, oh, thank you so much for doing that. But because it's so hard to get all of that information together, even from previous notes, and get the chronological order right. So I think we should have like a uniform health system, or at least EHR or electronic health record, which combines everything together, because it's hard and you forget things, and you sometimes forget the dates. And I realized after that, how I ask for those details, it's okay when people forget and then they get stressed out that maybe it's going to affect their care, is that it's okay. You can just say roughly in the 2010s I was diagnosed with this. Because as a patient, I used to get a little anxious, oh my gosh, am I forgetting anything? And that'll play a role in how I'm treated or not treated correctly. So that was the major thing. And then a couple of other things is just reacting to patients. I hated pity, and I got a lot of pity walking into the chemo suite every time, because I had my big belly and I was wearing either a bandana or a wig, which looked like a wig. And every time people kind of looked at me and looked away, but gave me a sad smile. And I just felt like they were all well intentioned, but the pity just hurts. The patient, as a patient, I didn't want pity. I just, I didn't choose this disease, but I didn't want pity. I just wanted understanding, and just, that was it. So the way I started changing that in my practice was that when I talk to patients, I treat them as equals, not like, oh, I'm your savior trying to fix everything, and I'm sorry you got this disease. Yes, but in a way in which they're like, yes, the disease is there. I'm here to help you as best as I can, and I wish things were different. But I try to stay away from that pity aspect. So that's me. I don't know if some people might like a little bit of that. I don't know.
One of the things that I recommend to patients, especially when they look very different as a result of their disease. So you had lost your hair, you were very pregnant. I recommend to people, now that everybody has a cell phone just about, I recommend that you show your doctors and your nurses, and if you're an inpatient, show them a picture of what you look like when you're healthy. So they can remember that you're a person who happens to have this disease and this setback, but here's what you look like when you're totally together. And I think it makes...
This is not me. Like, you're seeing me like this.
You're seeing me at my worst. And I think many times, because our healthcare system is so disjointed, and because we're so siloed, many times you're meeting a doctor for the first time when you're in the midst of a situation. They don't have it's not like this is your gynecologist who you've had since you were 18 years old, who's taking care of you. So I think that, that's a very important part, so that they can also see what you're trying to deal with in terms of not having your vitality or your hair or, or your eyebrows or whatever else, is missing or different. It's hard enough for most women going through pregnancy, just not having your figure, not having to deal with this whole...
I was like, I don't recognize who this person is, and then these people just see this person as me, right? So I think that's a wonderful suggestion, for patients. Because, I wanted them to see me as, normal, and I wasn't normal in any way, and I, or didn't feel it.
So there's a lot that we still have to get to in the story, and I could talk to you all day, and we're kind of running out of time. But I do want you to get into the issue of the complications that you had as a result of your chemotherapy. So I understand that you developed other medical problems, and I don't want to speak for you. So you want to tell us what those medical problems were?
So a few months after the baby was born, they had regular echoes, and I developed.
So an echo is an echocardiogram, which is an ultrasound test that looks at your heart.
Right, And they do it because some of the chemo medicine can affect the heart. And so they do it initially before they start, and they do it every couple of months after. And there was a drop in the function or how well my heart pumps. And so they said, you have to see the cardiologist. And that's when I lost it. I was like, you guys keep sending me to one specialist, the other specialist. There's nothing wrong with my heart. And I remember saying that, and now I'm like, how unreasonable was I? But when I got that call that, you can't get your next chemo unless you see the heart doctor, I just completely, lost it. But then I did see, and I do have a cardiomyopathy, which is damage to my heart muscle because of the chemotherapy. But the chemotherapy saved my life on one hand, but it has left a lasting impact, and I am on medications to prevent that from getting worse. It got better, and then it got worse 2 years ago, and now it's just stable, but it's not normal, and I have had to change a lot of things, but in the end, I feel like, I'm here with my kids, and if I have to take 6 medicines every night, that's fine. So that's one. And then just 2 years ago, I was also diagnosed with Crohn's disease. Now, Crohn's usually doesn't. That's
Hi, we have a visitor. You can say hello. We're very used to children walking in on our podcast interviews. Sometimes we've had pets walk in on our podcast episodes. Most people are listening, so they didn't see her peek in.
Yeah. So, so Crohn's is an autoimmune disease, and usually doesn't happen. Like I was like 39, 38, or 37, and the oncologist said because one of the medicines I had gotten called it's in checkpoint inhibitor, or it's an autoimmune kind of. It affects how our immune system works, but it's also very good in treatment, and it's actually changed the survival for women who have breast cancer, which is not just hormone positive, but also HER2 positive, which was me, which had a very high recurrence rate, which means it usually comes back after a few years. So I got that medicine for a year, and sometimes that medicine may, and nobody knows this, these are all speculative theories, that it may have triggered something in my immune system, which led to Crohn's disease, which is, again, my own body kind of attacks my colon, and it causes inflammation. So for that, I need to take long-term medicine, which is, again, similar to chemo, but in smaller doses.
Okay. And I assume you've had a colonoscopy already?
I've had a colonoscopy. That's how it was diagnosed.
All right. So the other problem with Crohn's disease is Crohn's disease can slightly increase your risk of colon cancer, which you're already at increased risk for because you have the BRCA2.
Right.
So you're dealing with a lot. How did you possibly go back to practicing medicine? And at what point did you go back to work?
So when I was first diagnosed with breast cancer, I just took time off then. I took about 6 months off because I was like, I was pregnant, baby, everything. Then I said I'll go back. And this was while I was getting some chemo. But after actually 2 weeks, I realized I just couldn't do it. I had to kind of drive out from my office and then park myself next to a subway or someplace and snap for half an hour before I had the energy to go back, drive home, which was half an hour drive. So I was like, this is not worth it. So I stopped working for about 12 months and then went back part-time. And I'd always wanted to do academics. And so I was like, okay, now I'm going to go back into academics. That's when I rejoined Loyola. I joined Loyola, and I was working part-time, or maybe I was working full-time. And when the Crohn's happened, and that's when I went part-time. Because I just felt like if I leave practice and I'm home, I just, then the cancer, the illnesses have won, right? They're going to be there. I need to get myself back, into what I was. Maybe I will never become the person. I don't think I am that person who was there before my initial diagnosis. But I feel when I am a doctor, this is something I always wanted to do as a kid. And I like interacting with patients. And I feel like I can connect a little bit better. And I should have probably been connecting like that even before my diagnosis.
It does make you so much more sensitive to what other people are going through. But I think one of the great things about being a doctor is that you get to focus on other people's problems and you're not focused on your own problems.
Just on myself. Exactly. So it's like I keep busy, and I'm like, well, it could be far worse. That's what I always.
Absolutely.
Like, right. So then you become more grateful. Okay, I'm still okay. I'm still okay. And so this is a coping mechanism, probably.
So how did you decide to move then from Chicago to Pakistan?
So that is something, I did my medical school in Pakistan, and I had come for residency and training to the United States, and my husband and I had decided we would go back after training.
Got it.
And just, things had kind of gotten, life happens. And then when my cancer diagnosis happened, I was just like, let's do that.
Oops. Are you there? I lost you for a second. Wait. Are you there?
I'm here.
Oh, sorry. I lost you for a second.
Now you can hear me?
Yes, I can. So you went back to Pakistan because that was your plan.
Initially, yeah. And things had changed a lot. And I was just like, okay, I don't know how long I have to live. And I was like, if the cancer ever comes back, I don't want to regret that my kids and I didn't spend more time with, their grandparents and even my grandparents and my mom and dad. So that was the reason. So we decided we will go.
Well, this has been an incredible story, an incredible visit. I'm so glad we got to talk. I'm so glad that your hair is back fully, and you're doing extremely well. And that you now are bringing this incredible perspective to all of your patients as well as to all of our listeners. So thank you so much. Where can people find you online and in Twitter?
So online, yes, I'm on Insta and Twitter. So on Insta, I'm endocrine_Dr. Sara, SARA8. And on Twitter, I'm Sarah Nadeem MD. The handle is at Sarah Nadeem MD. So those are the two places I'm most active on. Because in Pakistan, I felt like Instagram is a very good resource for patient education, so I'm working on that.
That's awesome. It has been great talking to you. Thank you so much for coming to the ladies' room. And we look forward to hearing how well you continue to do.
Thank you so much. Thank you, Dr. Donica.
Take care. Bye-bye.
Bye-bye.
That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donica. And please join us next week for another episode of In the Ladies' Room with Dr. Donica. Real conversations with real women about really intimate topics.